Hello everyone, my name is Rebecca Ahn and I will be the moderator for today's webinar. We welcome all of you to our platform. Today's webinar will be on the art and science of guided bone regeneration. This webinar will cover the fundamental surgical principles in regenerative implant dentistry, guided bone regeneration and guided tissue regeneration, immediates in implant dentistry, biological modifiers, and more. Furthermore, I would like to inform you all that you may receive 1 CE credit. You must stay active during the whole session, and at the end of the webinar, a pop-up window of a survey will appear on your screen. If you do not see a pop-up, you will also be receiving an email from GoToWebinar with the survey link an hour after the webinar has ended. Once you fill out the survey, you can expect to receive your CE certificate by email within 14 business days. As shown on the screen, there will be a question box in the panel board. Please feel free to ask questions in the question box throughout the lecture, as the presenter will address them during the live Q&A session after the lecture. Without further ado, it is my honor to introduce our speaker for today's webinar. Dr. Eric Park graduated from the University of Iowa College of Dentistry, where he got a dental degree and partook in dental research at the College of Medicine and the Dow's Institute. Dr. Park is a clinical faculty member at UCLA School of Dentistry and an educational professor in the Oral and Maxillofacial Department at Katron University Gill Medical Center. He is the co-inventor of the LISA short for lateral and internal sinus axis technique as a new sinus approach. He is actively serving as an experienced clinical faculty member for the GDIA Advanced Surgical Training Programs. With that, I ask that you give Dr. Eric Park a warm welcome to this webinar.
Okay, hello everyone. This is Dr. Eric Park, and hopefully everyone okay with the quarantine for the coronavirus. It's about 12 months for me too. So today I'm going to talking about some the simple exploring but yet effective protocol in the guide bone regeneration. So this is topic that everybody wants talking about. First of all, for implant, GBR concept is so important, and it's been for 3 decades. Everybody talking about it, a lot of research foundation. So today I'm not going to talking about all the detail, but roughly my old way from the guide bone regeneration to the kind of new last 10 years simplified method. That's what I'm talking about today. So my good sticky brother colleagues, hopefully Dr. Jin Kim stay home without any working. With I know he loved drinking beer, so hopefully he got good stay healthy and safe. So we were in February in Philippines, beautiful beach in Boracay, has a W Cup meeting. And we had it there, and then only thing was kind of this. I look at this sign was ironically say, "Do not wash your feet." So I know we have lots of the false information about the coronavirus with the sanitization. So hopefully the main message is caution for coronavirus and put on the mask and just wash your hand clearly. You don't need to wash the feet all the time. Anyway. That's the job. And this is my colleague from the Michigan group. So this is kind of, I see that the picture. And then, I don't know, we in the future, I don't know, since we're going to open soon on May or the clinic, the problem is how we get all the office set up. So that's another big issue. So before we're dealing with safe environment for ourselves or our employee, including our own patients. So I don't know the answer yet, but I'm going to focus on today about the guide bone regeneration. Successful implant therapies depend on the adequate volume of the bone. So I don't have actually pointer doesn't work, but you can see the picture down there is obviously there's a lack of bone. So on the right side, there's a bunch regenerate the bone, which is from the grafting material. So for the long-term success, we need a good bone volume. So adequate bone also give the good environment for the patient maintenance. So bone is very important. So guide bone regeneration obviously is a bone, volume of the bone. The thing is, another thing is important is soft tissue. Dr. Jinkin mentioned all the time our soft tissue course. The thing is, no matter how you well develop and successfully bone regeneration, but if you don't have a good seal, which is a kind of protective system, like we put on the mask for the virus, the same thing as we need a good soft tissue to cover the first barrier of the foreign bacteria. So the adequate zone of the attached keratinoid tissue, which is we can create before or after implant the bone developing and then implant successfully osteointegration. So carefully preservation of all the soft tissue, but if you're not, then by the time of a second surgery or during the first implantation, you have to consider all the soft tissue. So no matter how many times we're talking about, soft tissue is a very critical thing for the future implant success. So this is since it guide bone regeneration, let's talk about the bone first, because without bone, you don't have an implant placement with a stable osseointegration. So typically we'll say, well, 1 to 5 wall defect, so socket wall and dehiscence, fenestration, typically horizontal defect because a lot of time you got some perio involved, and vertical defect. And then of course, both horizontal and vertical defect. But obviously in today, I'm gonna more focus on the first top 4 category. The bottom one, I'm not gonna deal with too much because sometimes this is very, very challenging case. There is several ways to get away. But if you really have a good skill with a good technique, there is a chance to do. But obviously, the predictability is very low compared to the other 4 categories. So let's focus on that one today. So when we are missing the tooth, obviously the post-extraction socket will have always a challenging for question comes up. Either what about immediate implant, right? Early 2000 or late 1990s, we were all talking about the immediate implant placement. That's kind of like the fashion. There's a lot of pro and con, but we know now, we know all the false and fact, pro and con. Is it aesthetic zone? Perfect condition. Maybe 3 decades ago, you just plantation implant. Implant will be stay in the bone, that's a success. Today's, it's not. The patient knows all the picky point. They look at all the website, YouTube, they watch everything and they study before you come in the office. So they know exactly what's the papilla, zone of the keratinoid tissue with, before crestmal bone to the contact point, they all know that. So we have to, good presentation when you do treatment plan. How about tooth extraction resulting in bone loss? Of course, we know that. So to prevent it to losing bone volume, either vertical or horizontal, so we have to kind of plan when you start it. And then failure to the treatment bone result in the tissue defect. So that's I just mentioned about it. So always hard tissue first, but without soft tissue, there is no hard tissue gain. And then after hard tissue, soft tissue, and then always like chicken and egg. So it's always correlated. How about the timing of the implant placement? It is immediate and delayed. And this topic was when everybody talking about the immediate implant placement. So it was kind of get away now, but still same thing. The principle is not changed. depends on the case situation. Sometimes you just slow down. So let's go to the case one by one. So I think 2000, I cannot see the 2008, I think, because I got the panel. Treatment option for the implant surgery. There's obviously type 1. This is from ITI census. Immediate implant placement. Type 2, which is 4 to 8 weeks. Early implant placement following the soft tissue healing. And then 12, 16 weeks, obviously the bone healing much later, so partially bone healing. Obviously type 4, which is about 4 to 6 months, that complete bone regeneration, and then after you place implant and control the soft tissue. So let's talk about the type 4, which is late implant placement following the complete bone healing. So advantage is there are things which is you can control much easier. If you not much experience with all the controls of tissue and hard tissue regeneration, I think you can just slow down, right? Extraction, wait for soft tissue healing, and then you just adding bone as a GBR, and then after that you can place implant with the surgical guide or whatever that you can name it. So conclusion is average loose bone on the alveolar bone with membrane actually is considerably less to losing the bone. So the membrane is always considered about the guide bone regeneration. I know I don't know Jason signed up to this one or not, but you know he always asks, "Oh, you're not using membrane? Membrane. You guys all have a brainwash." So membrane is very important. So I'm going to discuss about all the fact later. So the late implant placement, you can really control that because you got a volume of the bone on the ideal implant position with the proper occlusion. You can align it pretty good. So let's go through this case. The patient has number 9 with previous root canal treatment with epicorectomy done. You can see from the PA. And then there's the kind of failed, right? So even though the tooth spin was a long time, the epicorectomy was not correctly done or something that still there is a cyst. So obviously the consequences you're losing the labial bone. But fortunately, I tried to save that crestal margin of the bone, ridge, and so try to not invading any incision. So I go through the mucogingival junction. As you see that, and then I clean well. Then you pack the bone and using the membrane, because reusable membrane. I'm not using the non-reusable because I don't have any vertical involved this one. If you have only my mistake for incision, I shouldn't get too close to the gingival marginal junction. I should get more to the mucosal area. So after healing, and you can see some of amalgam particle tattoo. So, but bone was complete heal, and soft tissue is very ideal. So place implant, and then was 2010. You can see there's a little papilla is shade is not filled. But if you wait enough, I usually don't see the patient right away because I don't do the restoration. So when I look at about 2018, 8 years later, I look at the panoramic. That time was, we don't have a CT, a 3D, but then we took the CD, combined CT, and then you can see the nice, good volume of the bone on the fascia. You know that 2 millimeter rule, right? So we're going to discuss about later. But anyway, so the soft tissue is a very creeping effect. So eventually it's coming down. The Tana group or some other, they said closer to the contact of the point of the crown is 4-5 millimeter skeleton coming down. So that's pretty good. You can control this case. Let's talk about the immediate implant placement. Most cases right now is about 90, 99%. In my implant practice, I try to do everything go to immediate implant placement with one stage cases most time, especially anterior, even temporization too, same time as surgery. So this is all the same. This guy's, I think it was a wrestling coach in Olympic Town in Colorado Springs. And he showed up and there is some, number 8, there is some soft tissue has a little bit of inflammation. Right? So obviously he got the tooth fracture, the root fracture actually. So the tumor pattern was carefully extraction, and I kept all the labial bone, facial bone. You can see the, and then all days we fill the socket depths with width. We put in the large implant, but obviously that kind of resorption of the labial bone. So instead of that, you can just palatally incline the placement. And then I'm using the patient own tooth, the broken one, to make a temporary abutment with a temporary crown. And then that way it filled it in everything. That time I don't using, right now you guys know all the PRF, CJ, punch technique. Those things I didn't do that, but still properly managing with the typical cortical particulate bone graft with I've been using membrane in this case. And then this is 2 weeks and 6 weeks and 12 weeks. So after that, the tissue is healed, no sign of inflammation and infection. So in that time, sometimes I did the prosthetic this case, but the Kamish used to be like the implant. Sometimes if you control good soft tissue with the temporization, you treat implant abutment as like a natural tooth. You prep the tooth, impression, final impression, and then just deliver the crown. So that's exactly what I did with the impregon and stable the analog, and then send to the lab, and then just cementation. So that's the case, different way to do it. So how about look at the other case? This is another fracture with the root canal. No infection, soft tissue is pretty good, very thin over the labial bone. So a lot of time I just try to extraction the root first. Instead of that, I just drill through the root, and then just that way I control my angulation. So by the time the angle is thinking about talking about like Dr. Seymour, figure 8 technique, right? So when you looping around with the floss or whatever your imagination line, it should be inside from the cross section, palatally. How about the socket shield technique? So this is a good indication. If you really want to do it, you can slowly grinding the label side. You can grinding that one. But by the time I just don't need a socket shield technique, I'm just using a typical sticky bone and PRF. So spray the rule is minimum 2 millimeter. So if you don't have that, eventually for the long term, you might resorption of the bone, and then soft tissue also losing it, and then it end up long-term failure. So we follow the rule, and then angulation, and then with the temporization with the temporary crown, and then you're smoothing out. I don't have a pointer, but you have to be really narrow down on the connection of the implant abutment junction. Otherwise, it's platform switching, but that give you room for soft tissue to more adapt. So that's another way to control that one. But this is on a short tooth with so contouring. So sometimes this is temporary abutment. You have to grinding that the abutment, the edge. You can just totally grinding up to make a concave, smooth S-line curve. But anyway, so using as that's a PRF or CGF firing, and then you just tucking together. We call it poncho technique. You know, like we're wearing poncho around the neck. So soft tissue is everything good, and then you just switch around it, and then you just wait for 3 to 4 months, and then this is a final. You can see the good the labial bone volume is soft tissue, and then papilla fills everything. So this is kind of like you can timing wise different way to do control this. So let's talking about okay. So alveolar ridge, bone deficiency. There is just so many different conditions with this different situation. How can we solve the problem? If you read Ray Carmichael's book, there's a mention about the different type 1, type 2, type 3 with defect of the bone style. You can have it. Typically, if you have a good bone height with horizontal bone loose, you can sometimes do placement, right? Because we love to place implant subcrestally, because old days you cannot do that. But now we have a good platform switching with Morris taper type implant connection, so we can place the implant deeper without any damaging existing bone. So we call crestal osteoplastic. How about ridge expansion split? Yeah, this one was also very, very popular. Last 3 decades was everybody want to learn and everybody talking about it. So this is a good one of the technique. It's fine. Still you can do it. How about titanium mesh 10th pole screw, which is a good tool if you choose the right case with the right situation. Well, another gold standard is block bone graft, which is very, very, very popular, because one time we are the implant surgeon, so we like to have a feel good when you cut the bone and harvesting bone from the everywhere, and we feel like we're surgeons type kind of macho attitude. So this is good. Still, some cases you have to do that. How about BMP2? I think in 2000, early, everyone talking about the bone morphogenic protein, which is a great, the war wounded, the soldiers, they have like bunch of orthopedic surgeons, they cure. Regeneration is amazing, the concept, and there was like very, very popular one time, but it's kind of shaded away. But still, some case you might have to be in hospital setup. And then there's a bunch of different guide on the regeneration with the future, what's the new technique. So let's talking about how do I managing this complication with severe bone defect. My old method. I'm gonna just little bit case by case. I'm trying to digging all my file, because since I was in about months to quarantine, and this is a good time so I can play with this my zip drive to the external hard drive to digging all the things, but barely I probably cannot even go through the less than 10 case. But anyway, let's look at some case. Anyway, when I'm using the old way, now I'm not using too much, but still particularly bone graft with the membrane, which is titanium mesh. I have lots of them still in my garage. Titanium reinforced PTFE, Gore-Tex, or just Teflon, and then tag. And I cannot see the, and then the 10th pole screw, Pepton P15 Gem 21, and as a growth factor. And then Of course, block graft and harvesting from the ramus, symphysis, tibia, skull, ridge split, bone expansion, BNP2 sandwich technique, histogenesis distraction technique. So anyway, so this technique I'll try to do everything depends on the case and carefully using for last decade. So let's go over the deep placement. This is our GDIA, live surgery group. So some of the gangs doing over there. This is the case over there. This is a very thin ridge. Obviously, there is an option when you guys look at this case. Can I do the ridge split? Can I do the something? Can I do the block? Maybe in old days, yes. But in Mexico, in the live surgery setup, we're not trying to do too aggressive treatment because, first of all, we cannot control all the post-op care. And then if the case went well, and obviously it's good, but if anything goes wrong with the complication, we're losing the problem. So the best way is just simplify technique, right? So it doesn't look like at the crestal ridge when you see it, very thin actually, but once you open it and then just thinking outside of box, when you look at it, well, we can place implant 3 millimeter deeper, right? By the time when you go down the 3 millimeter and look at it, there is a bone on the fascia, I mean the buccal side. So this is the kind of dentist has a guide wheel. So when you drill with the space, and then also the pin has exactly occlusal alignment. So this is another good thing. I don't do I know the Dr. Kevin Kim has a great the webinar to the guide, the surgical guide. So, but I don't have the luxury to go to the different office. Sometimes this is good that my guideline to the patient. So using it, try to close to the lingual side. I'm not going to perforate it, but using it as a Lindemann drill, so I control that, the line of the angulation with proper contour. So when you look at the right side, there is a implant was about 2-3 millimeter deeper. So now you can see from the crestal approach after initial prep opening, doesn't look like not much bone, but by the time when you place implant, it was not that bad, really. Has a lots of bone. Obviously, we're not cutting down the crestal bone reduction. We don't do anything, but instead of that, I place implant deeper, and then I decorticate it, which is we call the regional accelerated the phenomena. So we try to do all the inducing all the cell to creating the faster healing. So this is the line that initial that I want. And then basically I'm using sticky bone. And then since it involves some kind of corner vertical, we needed some build up the little bit height of the vertical. Sometimes I'm using membrane. This is non-reusable, of course. And then the tension-free primary codes. So obviously the patient cannot be chewing on this side and no mobility, no chewing, no look at pulling, moving, anything. Mobility is kind of unstable condition. It'll be not, the bone is not going to be adhesive. So those are criteria for the GBR. So this is the pre-op. Instead of that line that I'm cutting down the crestal reduction, I can just using it as a lingual bone vertical height, and then you just build up to the buccal side. So that's the ideal contour. How about ridge expansion and split? I don't do much, but still, once in a while, I can do like a Corey technique. But ridge split, which is been up for a while. So a lot of great either oral maxillary surgeon are very nice. They have a lot of Europe. They had this technique of popular. How about let's look at this case. So I do the ridge spring and then both low right and left side, and then also upper. So the height was not a really problem for issue, and then health-wise she's very good. And so we just do the split ridge expansion same time. So patient on right side, there's a little shy away and the premolar area, but I have to be maintained 2 millimeter rule. On the left side, also same thing, split same way with piezo, some cutting, so less trauma for the bone. So that's pre-op reach, and then after split, put implant in, and you can kind of growing the bone. I mean, typically 3 to 4 millimeter to about 6 millimeter. So there is a, when you look at the left side, is enough 2 millimeter, the volume of the bone. So now my marrow is good joint of the keratine tissue, soft tissue issue now, and also prosthetic for the occlusion, proper occlusion, and then maintenance, right? That's for the long-term prognosis. This case, you can see some of them maybe never using this is called external hex. Probably not much using now. Everything is internal now, but that time we had a very popular for multi-unit prosthetic. A lot of prosthetists using the external hex, they love it. So we're using it a lot. So but this case, you cannot place implant place deep because obviously when you place deep, there is a micro connection leakage. So bone will be dying away. So you cannot place deeper. The upper same thing, the split ridge and then place implant and GBR and membrane and cross. So this is post-op, about I guess 6 months around it. So this is the final prosthetic, and relatively is a good tissue and a good line of angle. Obviously, the occlusion is very key. Cosmetic issue, probably not the patient was high priority, but the function was okay, good. But let's talk about some other complication. When you look at the front central incisor, the bone is missing. Initially, the bone was very good, but these days I never do that, right? Either using the rigid compaction with the expansion or GBR with the contour grafting. But at that time, you know, just excuse me. I like to using the split, so I split, and I just still try to follow the rule. 2 millimeter from the facial side. So split, place implant, GBR, membrane, primary course. On the right side, tissue is really good. So I say, well, this is a good, well success case. But guess what? After I open it, my facial bone is, the ridge is all gone. So in this case, I have to do either redo GBR or just extraction, implant, remove implant, and then just start all over. So those are sometimes the upper maxilla, as a bone is somehow resorption very easily, plus it's labially kind of pushing. When you split, still like implant is too facially placed. So I wouldn't really recommend it anterior, especially for the ridge split on the front side. It's very technical sensitivity. How about titanium mesh with the 10th pole screw? So left side is titanium mesh. Sometimes when you look at the hole is too small, so sometimes you do the BMP, you need a large hole, so it has to be more cell communication easier. The other screen from the right side has just a tenting pole screw. So you build up the screw and then you're just building up. So that's, now how about block craft? In 80 to early 90, everybody favor for the autogenous form. So that's a classic standard for the all the severe ridge. We go to the jaw, skull, iliac crest. So people comes for the mouse fixing. They have like limping with the hip, bone is gone. So we look at all the things the last 3 decades, and also application, the only grafting, which is some other bone, we can still do that. I'm gonna do later presentation time. I'm gonna talk about the autologous tooth using as a block or a veneer technique. So the donor side, either Symphysium or Ramus, obviously, or trapline like Audi technique, and then or J-graft, which is from the chin of the lower jaw. So a lot of time I do some case, and the actual the donor side is a severe problem with all the muscle dysplasia, severe swelling, and patient went through the hell. So they never want to. They say usually never want to do it again. But anyway, so some other cases easy. Well, this one is missing 18 and 19. So a lot of times it's a good indication, because when you look at that, you're gonna just same side, because the donor side, if you're doing the left side surgery, you go to the right side and you just both side patient pain. But in this situation, is very ideal. You took the bone from the ramus, the angle of the mandible, and then you just bring it from bone to the front. So I had a good volume of the bone, and then engaging that one. So about 4 to 5 months, I got, looks like over engineering. It's about 10 millimeter. It's a good, nice, good healing block bone. The first screws came out, which is very nice. But when you look at the second one, I stripped the hole, so I couldn't take it out. So I had a question that time, either, I have to drill through this titanium fixation screw, or I just take it out. So I end up just grinding up, like a imprint remove, right? So almost like a mini imprint remove. So I was worried about it, because that block bone maybe come off, but you can see the picture. Obviously, it was a very solid welding. So after that, I pressed implant, and then second surgery, and this is 15 years follow-up, and still implant is good, maintainable. How about another block bone cases? The option was posterior number 31 is the mesial tilted. So if it's focation 2, maybe option sometimes take it out and both 2 implant, but patient want to save that one. So we have to do the one side, but then the position of the implant position, so I decide to the block. But since the angle is very curvature, so I have to section the 2 block, and each is 2 individual fixation screw. So quite simple and slowly coming up. But when I look at this patient as a post-op, when you look at that, what looks like, right? When you look at the post-op, you look at the little pimple like that one, they say, oh no, right? You know that what's that mean? Because there is some other fistula with the infection. So I took about 3 months PA, and then it's gone, right? Something different, right? The front side, the medial side of 29, I mean, the distal side of 29 is some kind of opaque, and the other one was nothing. So obviously that was happening. When I open it, the funny thing was totally gone on the adjacent to second molar area. And then the fourth distal of the number 29, still solid. So as you see, the GBR is anything you have infection, then you're going to lose everything. This is a good, very clean indication. So fortunately, I don't losing anymore from the pre-existing bone, but you can see the totally resorption that bone. But since this bone was a sectioned, so front side of bone was actually engaged. It's kind of interesting case where I look at myself. So anyway, so I have enough bone to the engaging to cerebral defect, and then I just do GBR. So this is a second surgery, and then I adding one little more, and then just do that. This is another case. Post-op, second, when you look at the patient about 3 months, and then now suddenly show something through to the tissue. Patient has nice tissue, but sometimes, who knows, they're eating something or something they do. Once you expose that soft tissue from the fixation screw, was kind of questioning. So I open up and bone looks fine. So I took the screw out and then I start with the implant, and then I just kind of expansion a little bit. By the time I tap, just boom, it's separation. There's nothing engaged. So what are you gonna do? Well, in this case, I have to re-screw back and like almost polytechnic, right? Just veneer and then put the adding more bone to fix it. How about BMP2 case? This is the lady from Shanghai. The severe advanced perio, when you look at this, so even I flap the sinus area, I have to push through the membrane. So I'm not just, I was very carefully flat, but the bone was very thin in the sinus. So what I did was I waiting about 6 weeks, and then I re-enter, and then I using as a BMP. That time was, its cost about 0.9 cc was about $850. That's a lot of money. So since carrier with BMP, we're using it as a color tape because this is a protein. So the liquid form, you mix it, you have to kind of how to carry this all the BMP protein. So I using it as a color tape and then soak it and then cover with BIOS with the contouring. And then about 6 months, I drill through. You can see the good bone regeneration. You can see the sinus area. This is about 12 years later, and you can see still from nothing to the develop about 20 millimeter the bone height. So let's talking about. I mean, the time goes really fast, so I'm going to go a little bit speed up. So let's talk about a little bit history about the guide bone regeneration. The early 1959 is terminology with barrier membrane, right? So is barrier something what? The field bone, they first talking about the kind of filtering with the millipore. So it segregate from the cell migration, right? So it prevented bacteria inside, or before bone regenerated, soft tissue migrate with the fibrous tissue develop first. So they might kind of barricade. So when you look at the GTR, guide tissue regeneration, early is Lindy with Neiman, 1980. So that's a concept application to the bone regeneration. So now everything guided, right? Computer guided, tissue guided, the bone guided. So that's a concept. So the membrane is very, very popular, and GBR mean is equal is membrane, right? So we got so much brainwashed. So we're talking about GBR for requirement. What is it? Because there's either non-resolvable or resolvable membrane, is adequate source of the vascularity. Yeah, cell. you need the source of the osteogenic cell. And then mechanical, you have to be stability until it's settled down. Like when you do the concrete patchwork, you don't want to step in until it's solid. And another key thing is scaffolding. You heard 1,000 times, maintain space. With that space, something fill it in. And that how develop early and secondary remodeling. And then exclusion of the competing non-osteogenic tissue, which is the concept of the membrane, right? You don't want to be fibrous tissue coming first before osteogenic cell to regenerate the bone. So using it as a protecting graft on the defect side against the invasion of the tissue cell. So this all concept comes in later concept of the sticky bone with the CGF concept. So barrier membrane, there is obviously collagen 2 type, either long or short term. Like collagen is short, and then BioGuide or some other Bioman is long term. Some of them 6 months to the R6 is about much longer. How about titanium reinforced? I know the Sasha, Massimo Simeon, or Urban showing the beautiful vertical case with this GTR. I mean the titanium reinforced case with the fixation screw. So a lot of cases still works good, and still some cases needed. And then the other one was either small pore or large pore of the titanium the mesh. So to fix it has a lot of different tech and bone grinder, scraper. Those tech things are all we're using for the last almost 30 years ago. That's the kind of standard for the GBR armamentum. And so still, I don't mean that as I exclude the membrane. I still like the membrane to using some case, but this is some case I using a lot a long time ago with the PTFE membrane. Obviously, tissue integration is poor. This is higher, and vascularization is poor, and biocompatibility poor. The resorption time, obviously, you have to second surgery. So you got a more invasive way, but once you success, you got a great condition. So this is the case like, the osteohealth has the non-reusable one, not titanium reinforced, but still has the PTFE suture, I mean the membrane. So you fixate it, you got the marginal vertical ridge involved. So by using it, take it, weight, and was nice bone regeneration. So this is titanium mesh with 10-pole screw. So some other case with titanium mesh, I did that pretty wide between the crestal alveolar ridge. So I put it in, and this one is titanium mesh is very friendly to the soft tissue. So you can see the post-op infection. Once you got an infection, you can see from the pre-op and then post-op, you're losing more bone. So how about Corey's technique? Either you do complete block or veneer and make a space, like almost rigid split separation, and then adding it. So this is a kind of good space maintained with the patient own bone. But another way is once you're cutting the bone, even though patient own bone, still dead bone. So there's many things to control, way to do it. Not just one technique works for all. So anyway, using that grafting and then using as a non-reusable, what they said was initially you don't need the primary cause. You just reopen it because its cell can be a pass through from the periosteum, but bacteria can get in. So once you're building up, you remove about 4 weeks, and then there's under there is develop the keratinoid tissue. So, but when you look at this carefully, in these days, I'm probably not using it. So when you look at that, beginning was not really primary cause, but I had a good keratinoid tissue on the buccal side. But after 4 weeks, look at that, what's happening? I'm losing all the pre-existing keratinoid tissue. So this is kind of undermine regeneration of the tissue. But why are you losing pre-existing good tissue? So that's kind of my argument. Another thing is this is maybe I'm using as a fixation with cover screw. Maybe these days I might be using as a healing abutment, but that may give more room to space scaffolding. But that time I'm using it because I have to primary cord. So then I do that. Well, once you're opening like this, right? Soft tissue is opening, and the bacteria goes in, and I remove it. Yes, still kind of regeneration under there, but it wasn't really ideal situation for me. So now I cannot grow over the implant, not just level or below the implant, the first thread. So that's not my the acceptable way. So how about the barrier membrane with the visible membrane, like a BioGuide, like it? I think relatively it's good. I still using in a case. So I either combine with it or just stick with the PRF or CGF press type of the membrane like. So all this block with harvesting from area, rigid split, bone expansion, BMP, or particularly with all the different technique. If your soft tissue is once you opening and membrane exposure, then a lot of time, not sometimes, it's more disrupted. So I don't gain much. So I actually losing. So my question is, how about more practical and efficient, simplified way, right? So that's always we're looking for. If you listen to some of the sinus approach, we always a condition instead of the more complicated, it was simplified. So we, as a ASAP protocol, now it's more popular to name sticky one. Everybody talking about sticky one, CGF, Dr. Son, DS Son, good core GDI colleague. And sticky one, either I'm using Allo and Geno with autologous fibrin glue, which is, if you're not familiar this term, I'll discuss you later, and concentration growth factor or pellet-rich fibrin gel without reservoir membrane. So with this protocol, I get more less soft tissue dehiscence with no membrane exposure because it's very friendly. So this way approach is I always reconstructive and additive. I never really losing much in case infection. Because of the trauma from the surgery, I might losing some, but always I gain some, not like the other way. So this is kind of the name comes out from the ASAP trauma. But anyway, Dr. Son and Jin Kim and we on the way from the Tijuana to the LA airport, they look at this and then their name comes with. So then we published the article with a sticky one. First term as a sticky one has much easier to handle. So let's talk about now. We're talking about CGF, PRF. So let's look at the history a little bit. I still have some time for go through the PRP. First, we know pellet-rich plasma, which is a lot of orthopedic surgeons they're using as a medical college. So the Miami Dr. Robert Mark, first he comes with this a lot of application to the dentistry, and he did a lot of surgery with the PRP. So this is smart clamp, and they spin down two separation cell, has a very concentrated platelet. So we know that planet has a lot of the growth factor to the either soft tissue or hard tissue regeneration. So let me go through the quick one case for the PRP case. So native collagen membrane, the PRP and bovine thrombin, which is make a fibrin clot, and then platelet poor plasma, which is good for the tissue with calcium chloride. So I'm using these two chemical, and I spin down twice with high RPM, and then I just mix into the either geno and mineralized cortical cancellous bone, and you can see it. But that time I using some of the bovine thrombin and calcium chloride, but I don't get solid like sticky one as now, but still I have some kind of control, right? You can see I can grab some of the bone, and then I using membrane, and this is what PRP protocol. So the second centripede with the very concentrate, only bottom, but you don't get much volume. So this is the first 6 months, I guess. So either sinus same time with ridge contouring or the GBR. So crystal from the GBR, under the sinus we adding the both side. So I using it a tenting volume. I don't gain the full, but I still have a pretty good amount of control. But since the FDA black box label say bovine thrombin should be maybe cardiac arrest problem. So right now is nobody using the bovine thrombin. So there is another story like PRGF, but I'm not going through all the things. Some point Dr. Jenkins gonna go through all the training, but we have the PRF. It's so popular. Dr. Joseph Chokran. He came with this one, but he's not a dentist. He's an MD, anesthesiologist. So he produced an article with Dr. Dohan. He's very young, bright, the scholar. So he showing a lot of published article with PRF. This is fibrin. So instead of PRP, all the fibrin clot, the PRF has contain all the growth factor. So this is the machine that post their and then you can see the serum with the PPP and then PRF, and then there is a puppy code connection, and then there is the red blood cell. So he did a lot of research and published the journal, so you can Google yourself and then read the article. He's tons of good article there. So first fibrin network compared to C concentrate PRP compared to the PRF, there's a lot of growth factors in track. So PRF we know is good. So from injury to the healing, wound healing, there's a fibrin clot, and then we know a lot of cell migrate to the wound site to regenerate with the cell stimulation. So there is a leukocyte has a great work as a releasing growth factor. So obviously there is some other puppy code has a CD34 plus cell with all some of the stem cell, but I'm not into that so much that the stem cell talking about. So somehow Dr. Chokran came to the US and tried to get into the interlock, but he kind of pushed away. That's what the history comes with now. Dr. Chokran is on with APRF, but I don't think it's LPRF, APRF, the different, the centrifuge with the speed, and they said more, we got more cell with more concentrate factor. All those things as a researcher, but as a clinical point, some of the machine works fine. Currently, I'm using as a first Chokran PRF machine and also Medifuse CGI, which is concentrate growth factor. Dr. Rodella from Italy, he has a lot of Professor Rodelli research for this, and then Dr. D.S. Son has in Korea, he got a lot of research and protocol. So LPRF and APRF, IPRF. So anyway, from the CGF has a more stay longer. It's not a membrane, but kind of fibrin pressure type of the gel, which is stay much longer. So Dr. Chokin one time APRF system, and then they don't have a liquid form to mix the bone. So what they do is a PRF. They squeeze it, either cut it and mix to the bone. So it wasn't like really stick together, but kind of now he call it sticky bone, but one time he say sticky bone, but that's gone anymore. That has no more tongue. Anyway, so this is two wire. One is very rough, like a concrete. So when you spin down, the cell is kind of clumps together with the clot. So that's the PPP, the middle part, and then the upper part, and middle is fibrin PRF. And then bottom has a bumpy coat, which is kind of a lot of cell connection with the red blood cell, the red blood. And then, so we just discard the bottom side. And then how about the one on yellow cap? Well, sometimes we're using the white cap with it. It's a non-coated tube, so we call it autologous fibrin glue, AFG. I'm using a lot of medical therapy with facial rejuvenation or hair regeneration with the lip, a lot of the things. You cannot injection with the PRF, the fibrin clot. So you need some kind of liquid form. So this is kind of smooth surface, like your ice on the road. It's very smooth, so still liquid. Eventually it'll be the fibrin clot. So that's easy to handle to carry on. So some of the patients, they want a hair with a cell. So a lot of major therapy in the vampire face lift. Now the medical guys so into our technique to back instead of PRP. Now we know that platelet has a lot of growth factor in it, either soft tissue or hard tissue. But of course, the facial has a lot of soft tissue. So PRP is a high G-force, and then compared to the PRF, it's a low G-force. Now all the medical plastic surgeon, they get into the PRF. But the terminology actually is wrong because it's not fibrin, it's just autologous fibrin, the liquid. So anyway, so this is the stone with Dr. Jim Kim. And we creating some other like this one. So autologous fibrin gel, you took out the middle part of the PRF, the rich liquid, and then some at the bottom has a CD34 with all the cross factor with thrombin. Then you make our sticky one like this. So it's very consistent. When you look at all the participants, first they shy about this, but once they grab that and it's so solid, consistent, and when you look at that after 2 minutes, look at all the particulate grafted is now become a one piece. I think next week, Dr. Daniel Hadiji, he was talking about something molding, which is a very interesting topic. Maxius, some of the Korean company has already come out too. So yes, molding is amazing. It's very easy to handle, but this one still okay. But when you look at this, all the docs with the students, first time they were very shy about the prep. Now once you get there, very, very aggressive. This is Kimberly, which is an interesting, big, huge CGI. So now we got PG now, so let's go on next one. So the point is this, the GBR. To success for the GBR, obviously, it's like when you building the sand castle. One on the left is Barcelona beach. One is right is Philippine Boracay. So obviously the same sand, maybe some other different component with the texture, but the bottom line is this. Nobody care about all the design or, it's art, but we're all thinking about like pinpoint, right? How they build the tower like that, how they control the Sharpie point is sand. We know that sand is just, it's not solid material, but how they build like this, and then just stay, maintain, and then control the structure. So this is the way that we focus on the GBR. When you do the GBR, so many things. We got the same bone material, same membrane, same under the tissue condition, but every time we build the bone, it's gone. So now I'm going to focus on next 20 minutes, ASAP protocol. So with our membrane, CGF, sticky bone, allogen. So let's go over. So we do multi-layer, either layer technique by allobone first and genobone, or mix it together, multi-layer, then multi-layer of the CGF or PRM, same thing. And a lot of cases are not using membrane. The rationale for using of sticky bone, I think the field bone in 2001, but a lot of Daniel Buja talking about the contouring graft, right? So is actually from this bovine bone or xenobone with not much resorption fast is actually acting as a barrier membrane capacity. So this is concept that makes sense, but we're using it as a lot of growth factor mixing together. So this is my since the last 10 years, more stick with the stick bone, I'm stick with the sticky one right now. So many cases, this is 2016 with the GDIA case report. Low posterior case, delay with ASAP GBR. So remove the tooth and a little bit of a curvy contour. And then obviously Crestor has, we have a choice to deeper place the implant, but obviously a lot of GBR needed. So decorticated, typical sticky bone. I think I'm using membrane and then CGF on the top and then suture. 6 months later, and I look at the layer of the grafting, sticky bone layer. The contouring layer is stay there. A lot of time in old days, I flap that. Those grafting bone comes out with my soft tissue side, periosteum. That doesn't mean it's not bad, but but this is so stick to the bone. So from the original recipient side. So I place implant deeper and then one stage approach with the contour technique. And then this is nice grow and then finally finish. But so when I'm looking at it, I say, I want to feel the texture. So, that bone material, sometimes old my PRP, it wasn't solid. I cannot scratch or scraping, tapping. So I want to try. So I call it tapping and scratching move. So I did that, and it was like a really concrete with the gravel. So that was a quite good feeling. You can see, I don't know, tapping sound, but it was a quite nice and solid one. So that's probably 2018, and then the still maintain the bone on the buccal side. You can see and so the pathway is the same, similar to the Daniel Buzer principle of the GBR. We call it pathway. So which is Honmei Wang in the 2006 primary cause of the wind. We know that angiogenesis, same thing, blood supply, all the anti-pressure mesenchymal cell to any soft tissue part or hard tissue part. To work on the cell on the regeneration side, we need a space creation and then make room to stable tenting, maintenance, and then stability of the wound. So this is a main good criteria, right? We call passive. Remember that. So how about lower anterior case? So when you look at this anterior, it's a lower anterior is very tough. Sometimes, I call it people just the breeze, right? The breeze is still stable, but patient really insists to lower anterior mandible. Sometimes the implant is very hard to get with the bone regeneration. In this case, it's hard to do the block and while registry because the angulation and adaptation of the block. Maybe cortical with veneer, bone, label bone, maybe that's another option. So I do the stick on the ASAP protocol. So decorticated, you through, a lot of bone bleeding, right? So rare phenomenon. And I'm using the sticky bone with the layer technique. You can do multi-layer of PRF and then close it. It was 3 months later because I think I have to go to some country. So I used to travel to Denver and then I opened there 3 months. And then patient was appointed, so I opened up October 9, and then bone was there. Nothing was solid. So when I drill it, you can see the line of the contouring line was still nice and solid. So was feel pretty good. So Gene Kim used to talk about selective cell repopulation, right? So differentiate fibroblast for the soft tissue and the osteoblast for the bone regeneration. This is a good space maintain and separation. So when you look at this one case, the patient comes with an extraction and immediate bone graft. They did it, one periodontics did it, not the socket graft actually was a quite defect. You can see that. So buccal and horizontal. So when you look at that, what happened? Somehow the particular bone was passing through, bacteria goes in, and everything is fibroblast cell. When I open it, I start scraping, everything comes out. So nothing was really regenerated. So I clean up everything and sticky bone. I using membrane. Sometimes if I have to anything little bit involved the vertical, I would using the reservoir membrane, and then CGF cover, and then primer close. So now I do more cell repopulation like osteoblast cell on the buccal side. So then I put open up, and then we got good healing of the bone, and then implant with the final prosthetic. How about lower posterior case? Immediate placement with ASFP GBR. Again, mandible anterior is very tough. Sometimes, always, I hate those kind of situations, right? 3 to 4 thread just showing. So this is like, I don't want to go second, the delayed approach. So I place implant, same time GBR, and I cover. And when I opened up 6 months later, then I was kind of like a little bit surprised because it just bone overgrowth covered the implant even. I didn't expect that much, but so I had to grinding up the exposure of the implant, healing cover screw, and then I open up, and then I just check it, see how it feels. So that was kind of like, I mean, it's not a huge regeneration for the GBR defect, but still, those are always kind of, for me, was challenging. So a little bit thread the hole, and implant is almost like outside the box a little bit, but now is totally covered with 100% regeneration bone. So many case, it works pretty good. So now I'm going to talk about just the last 10 minutes about autologous tooth block with particulate grafting. I know the doctor, one of the GDI faculty, Kevin Kim, Jill Park, she done it a webinar a couple weeks ago, I guess, and a bunch of doctors has this one. So they had a tooth block and particulate bone graft. We have a symposium in 2017, I guess. So this is not a new concept though, right? In the early, Dr. Urist showing using as a dentin. So organic and inorganic component. So which is kind of nice that osteoconductive HA or TCP material, plus organic component is BMP and then dentin matrix like protein. So inductive. So and then also this machine has a very good as decalcification compared to calcified dentin. You know that there is a machine available like Cometa, I think it was tooth grinder, and then there's some Italy has a tooth transformer, which is kind of decalcified, but the processing was a little bit simplified. So the Son has a lot of lecture with the YouTube and Facebook. showing as a different way of veneer, block, and particulate. So many cases was interesting, and some other case I involved. So let's talk about the particulate case in upper. And you look at the anterior, the severe defect with a lot of perio was a fixed partial PFF the things. So by the time they removed the tooth and let the kind of type 2 or 3 soft tissue healing first, right? Nothing healing for the bone, but soft tissue first. Then we go through the GBR. So when you look at the left to the right side, there's a huge defect on the number 9 to 10 area. And I had to involve because huge the anterior foramen, inside foramen, so I have to remove the partially and then I graft it because when I drill through, there is a communication. So I have to remove some of the nerve system with the artery inside foramen. And then I do the implantation same time with the membrane, CGF, and then close it. So tooth particulate material, but same thing as a sticky bone ASAP protocol. So about 4 to 6 months later, I open up and I was surprised because the point of the initial surgery, I put the bone, the same amount of remain into the post-op 6 months later is opening. So I had to grinding the sticky bone, the mature sticky bone, so to expose the implant. So then second surgery, and then final prosthetic. So this is the time of the surgery with the grafting, and then this is the, I think 6 months later with the post-op prep. So this one again, it's the same thing over and over, but I want to see that how solid bone. So you can see that number 9 and 10 area was totally defect, the buccal side. Now is a lot of bleeding with a totally regeneration bone. So now we know that it works under the condition of all the good environment. Obviously, there is some other risk factor, that soft tissue and some other, patient health issue and everything. So this patient later, I took I post along after for a while, and then I look at the crown. Even pontic, they probably give them more room to soft tissue instead of pushing away with the prosthetic, because I think bone level was not that bad. I know that this is the almost like very end-to-end position, so it's kind of hard. But I mean, clinically acceptable patient was happy, but my wish is a little bit more prosthetic-wise, the soft tissue control. That's another matter with in this case. So how about the block case, autologous tooth block case? This one is number 18. I tried to save it, but it's always down to the apex of the root. So I sacrificed that root, I mean the tooth, and then I'm using it as a block case. So this is kind of processing. You cut up all the amalgam and enamel function. You clean all the root and a lot of pores, and then you just decalcify. I think this is about hour and a half, 2 hours, I don't know. And then we have a RISA, which is a sinus, lateral intersinus access drill, which is a reamer drill. When you see the nerve, it's very close on the lingual side, so I have to using this drill with the stopper. So this is about, I think, 5 millimeter, 4 millimeter. So I drill it very close. And then it's called ring technique. I put the implant same time with kind of the ring shape. So put it stick together. I mean, this is kind of sometimes a challenge because if you have a room, there is from the autologous block, and if there is some gap, you might have soft tissue invagination. Then everything is not a good way. So challenging for the little vertical side, and then I also adding in addition to sticky bone and CGF, no membrane in this case. and then obviously periosteum release enough, bring from the buccal to the lingual, and then no tension, and then you can just primary cross. And then when you go back, so this is pre-op to post-op 3 cone beam CT, 18 area. When you look at the pre-op, a lot of buccal side vertical is gone, but the post-op case 18 was pretty good. So this is opening, and then I had some little bit resorption around the implant, but implant was solid, and then the obviously number 19 one was totally covered, so I had to grinding up to expose the cover screw. So then I adding another second surgery with sticky bone, and then CGF as a puncher technique, and then just go through that. So another way to using your autologous tools, I usually section the coronal part, crown section, and then using as the septum as a guide. I drill it because after extraction, by the time you ruin some other bone, the buccal bone or whatever, the septum bone. So this is kind of way to good guide if you want to do the immediate case. So just regular drill, and then place implant. Usually it's pretty solid, and then place a little deeper, and one stage with the puncher technique and sticky bone. That's kind of typical protocol. This one is like almost looks like a socket shield technique, but I just basically, grinding the lingual side and drill through it. And then by the time when I drill, final osteotomy, the labial, the half tooth came out, root, very cleanly. And by the time I see the good, nice, the kind of figure 8 angulation, and then just adding some bone on the facial, and then puncture with very simplified. So that's another good tooth guide, surgical guide. So let's go through the one final case, the veneer case, autologous tooth. So 5, 6, 7. So this is a before and after. We got pretty good bone. So when you look at that, number 5 has a lot of defect on the facial alveolar corner with the vertical. So I'm using it as the autologous tooth to veneer. So adding as a veneer technique, and then like almost no fixation with the Cori technique. And then you just CGF with ancho and primary close, but it's one stage. So this is after about the final prosthetic I saw. I was surprising again. The same guy actually processes. I'm not trying to criticize, but come on, I give them all good bone. I give them all the good tissue. But this is like a denture tooth, like almost, I don't know what kind of using the leg. This is almost like a, flipper denture. But this is, thank God, this is an implant with pontic. Can you do like this? And then the soft tissue kind of, re-creeping it and make it much nicer. I mean, patient was totally happy, fine, but if you process it like this, sometimes it's a maintenance problem, right? Eventually, if you have that, then you might inflammation of tissue, you're losing the seal of the keratinoid tissue, then you start losing the bone, right? So look at this case. What do you think? So what's this problem? Obviously, it's lots of problem. I don't know, this is not my case, but I saw this patient, they say about a year. So I don't know how the beginning, how you started, but what about soft tissue? What about bone? What about implant? Position, design, type, connection, prosthetic, occlusal, you name it. Everything probably not a good against, right? So always when you treatment plan for the GBR, bone soft tissue first, you're thinking always the bone, right? Now you have to think about the soft tissue. What implant system you're using? What my angulation, what's the implant position? And what type of connection? And all these things is a key factor to the maintain your GBR success for the long term. I'm talking about not 1 year, 5 years. I'm talking about 10 years. So this is, external type. Look at how much you bone lose. So obviously soft tissue problem, maybe the connection problem, occlusal problem, who knows? There's so many case involved, but you see a lot of this kind of case. Even mine, maybe 1,000 case, I didn't see the patient, but they living like this, right? Patient has no symptom. Implant is solid, they can chew well. Sometimes bleeding from the gum, but they don't just come to your office and say, Doc, can you open this and see how much bone I lose? Nobody say that. So we are the one who, now we are under stress of the coronavirus, but then hopefully when you get back to the work and we just kind of recouping and we give the good patient care. So we usually like 20 years ago, prosthetic guide. Everybody say prosthetic driven implant dentistry, right? That's a typical our prosthetic treatment plan. But my smart alecky sticky brother Kim said, how about GBR driven implant dentistry, right? So if you do GBR, every implant, this case is so much demanding. GBR success, we know the technique, we not have a lot of way to do it. But at the moment we fix it, it doesn't, the end is maintainable. And then is a GBR is success with all the prosthetics. So it's just the in circle. So hopefully to get all of this success with ASAP protocol, my take home message is we can double the volume. So that's what it is about my take home message for you. Thanks for the listening all it's a long hour. I think I passed 30 minutes, which is not bad. So next week, I'm going to announce that the another free live webinar with Dr. Daniel Hedges with marvelous Nexus linear bone with alveolar bone visual augmentation. Very interesting topic. And then obviously sixth session with Dr. Jin Kim, Beyond the 3-unit bridge with for arch cases is very good. He's been teaching this course for the, I think 5 years something, but it's very you get a lot of out of this. So hopefully you can join this. And then now I have to, my key time is up, so I have to go quick. But anyway, I'm gonna answer some of the question. Ellie sending me the some question. Say if the case needed bone augmentation plus soft tissue augmentation, which one we should perform first and why? Okay. Okay, 4 questions, that's good. All right, this is already challenging, right? So I guess by the time when you're teaching the soft tissue course, by the time place implant with bone graft and soft tissue together. But that's a lot of, asking for the patient under condition. So if you're not much, soft tissue part is actually, it's very tough because soft tissue is for me, is more harder than just GBR with the bone and then implantation because your suture technique is very, very key, and then control all the donor side or some of the aerodome or some of the material that we're using. So for me, if you like some of the case I show, the delayed case is a large defect. You cannot complete close because I'd say adding a lot of volume, but you cannot put so much bone and then you cannot close it. For soft tissue, then what's the sense? You're gonna make more trouble. So I do step by step, always additive way. So if you lack of soft tissue, you might have thinking about soft tissue graft first, and then with the big GBR, the implant. But if you have a minor cases, and then you can do same time. But I think it's first thing is the soft tissue always, right? Because without soft tissue, how are you gonna grow the bone? Because there's no protection. So that's the kind of my short answer. If my answer is wrong, then Jinkin gonna be answer later with his session. So how much bone lose? Too much for the implant placement. In general dentist, I want to know when not to refer patient or surgeon, educate patient about removal denture instead. Okay. So I tell you what, the tough area is the anterior, right? The maxilla. We know that is a mandible is much harder because of there's not much blood supply, so it's hard to regenerate. But the upper is very resolvable fast, even though a lot of vascularity, and then it's very cosmetic oriented. Mandible, no one's showing the the apex of the unless you're showing like lip, but maxilla. So those areas, if you really peculiar, and then if you severe bone loss, even though you do the fixed type prosthetic, is very challenging. Even the pink porcelain, whatever, sometimes you just had a hard to control the cosmetic and soft tissue. So that way you make like canine to canine and nice fixed unit. That way, if you a lot of because canine usually not much bone loss compared to the anterior part. Even low, same thing. So I don't usually put number, incisable mandible. The very small thin implant like 3.3 or 27, but 3.7 sometimes very challenging. And otherwise, if you overall general patient has a problem with the posterior or the problem, you have option like Dr. Kim's, the full arch, immediate, or on 6, or on 4. Those are options. Because sometimes sinus augmentation, posterior mandible to, vertical, because you got the nerve, right? Alveolar nerve. So those are, you cannot damage it. There's some other subperiosteal implant or some other technique, but if you severe case, you might have oral 4 or oral 6 option. Because you might, instead of saving a 4-6 tooth, instead of that, like a clear choice. They use everything out, make a nice osteoplastic, and actually you get the more bone. You got the more volume with the bone eventually. So that way, with the FP3 type of the connection, because that's cosmetically good and function is good. So what is the autologous fibrin glue? So how do you use it? Okay. Same thing, PRF and AFG. Same. One is the red tube, which is very silica coated tube. So it's a lot of roughening. So when you spin, the cell, the blood cell is with the fibrin cut. That's why I give the fibrin, right? And then autologous fibrin glue is the tube has a smooth surface. So it stay kind of cell with separation with the spin with some centrifuge, but still liquid form. So that way, when you make a sticky one, you have to soak it with liquid type. You withdraw from the syringe, and then you just soak it into the particular bone. Otherwise, the fibrin, how are you gonna? You just squeeze it. Sometimes you don't know how much really pray that which fibrin liquid comes into the dead bone particle. So that's the only way we separate. So we, in our GDIA life surgery clinic, we teaching how to make it and how to application. So those are basically same concept, same material, but the way how to deliver it, that's a system. So that's called the autologous fibrin glue. So now all the system, even mesotherapy from the plastic surgeons, they using as their machine, that using that tube, so doesn't make a fibrin cut, PRF. So that way they can inject to the face or some other hair area. So that's how we're going to using it, because we make a sticky one. That's why we're using for that liquid. Okay, otherwise all the PRP concept, we don't need to. Just PRF, you're using as just cut and packing into the socket, wounded, whatever the site, compressed, and then like membrane, like kind of gel press type, then you can just PRF is fine. So only liquid form we need it for make a sticky bone to mix the bone. Okay, and then is there implant brand or design that you feel very successful that you prefer? Of course, this is GDI with dentists. So dentist implant is very good. I'm just sure. So these days, old like the Nobel Biocare, right? I'm sorry, like all the Nobel user and because old days Nobel with Nobel Prize or whatever, that their connection and design is very poor, right? So that's a lot of fracture, and then some other the connection is weak, so it's a lot of long-term failure. I mean, some of the implant is okay, good. So what it is the connection part. You have to be a more taper type, like ankylosing, the dentist, all the Korean implant, Extra, Straumann, they all copied it and platform switching, which is kind of concept. So if you have that connection with RBM or the sandblasting surface, whatever that implant is pretty good. Design, micro thread, I'm not worried about so much, but those are like SLA surface coating is RBM. For me is not much big difference, but the important thing is the implant connection type, and then most taper type. So then when you place subcrestal 2-3 millimeter below the crestal bone, and then when you get the connection has no micro movement, that doesn't mean it's a micro leakage. That means it's stable. Otherwise, bacteria goes in and then start getting infection. Then you're losing all the bone. So that's a kind of how you choose the thing. So the dentist has a good. I'm using the dentist with the connection. So all the Korean company, they learn from all the failure mistake. So they copy the good thing. So that's I prefer. I mean, using whatever the feasible too. And then some other option is I don't have my own office, so I go to the office that whatever the doctor they're using it. But I peculiarly the system don't have those connections, then I don't place implant subcrestal. Okay, so I think that's it. Thank you for everything, and I'm gonna turn over to the Rebecca, and then if you have any question, I don't using Facebook much, but you can send me email or text. I do Kakao Talk, but anyway, thank you for everyone. Keep safe and healthy. Bye, guys.
Thank you, Dr. Park, for sharing your knowledge with us today, and thank you everyone for your full attention. I hope everyone enjoyed the webinar and found great value during this session. Please be informed that GDIA will be hosting the second session of the Beyond the 3-Unit Bridge webinar series next Monday, May 4th. Please contact GDIA at info@gdia.com if you are interested in registering for the program, as it is not yet too late to join. Furthermore, we have another free live webinar prepared for you next Thursday with the topic of applications for Maxius laminar bone and the alveolar ridge augmentation as shown on your screen. We'd love to have you join us again then. Thank you, and we hope you all have a great week.